CataractCoach.com, resident case 260 with a pupil ring. I mean, very good technique here. Talented young surgeon, but do you actually need this ring? I'm watching the video for the first time with you. We got a 2x speed here. Let's take a look. Draping's tolerable. There's the main incision. Not too bad. I like how you hit the limbal vessels. That looks pretty reasonable. Here comes another incision here using the same keratome. I'd like it if you use a smaller blade. You don't need that big keratome just for paracentesis, but okay. Let's see what we get here. Maybe some anesthetic going inside the eye. Look at the pupil size. To me, that's already a pretty good pupil. That's at least 5 millimeters, maybe 5.5. We'll find out. And I think you don't really need a pupil expansion ring here. So here's some viscoelastic going inside, maybe viscomydriasis, maybe tending up the iris a little bit to make placement of the ring easier. That's probably what you're doing here. So in these kind of quadrants, a little more viscoelastic, but you see you're prolapsing viscoelastic from the incision. So you're putting a little too much viscoelastic in there. But let's take a look here. Here comes your pupil expansion ring. Okay, got the Malyugin ring there. In the USA, these are at least $125 per use and not reusable, so single-use devices. Here you go, going inside the eye. Now, let's watch the technique. So delivering it. Let's see that leading scroll. Get that right on the iris. Good job. Here's where you need your second hand inside the eye to help. This is what you want. Second hand inside the eye. Okay, 2 trailing scrolls. Can you get the subincisional one? Yeah, just do it with that. Hey, there we go. Other hand. Nicely done. Almost. Beautiful. I like that. Good job with the technique here. But again, you didn't need the pupil expansion ring. So you had a 5 millimeter pupil. Now it's expanded to what, 6.25? Okay. Now let's watch the technique here. Now these rings do come in 2 sizes. I think, what is it, 6 1/4 and 7 millimeter pupil? But let's take a look here. Here you got the rexus with just the forceps. Very good skills here. Clearly you have good hands and you've practiced. So getting that rexus going around. Nice, generous rexus. I like that. So try to keep it pretty even going around there. Remember, once you get that ring inside the other pupil expansion ring, you can actually center it up and move the whole pupil around. You can put the pupil right in the center. So good looking rexus. Probably a 5 millimeter rexus there. Let's see some hydrodissection. Let's see your nucleofractus technique here. Now, you don't want to prolapse the nucleus out of the bag if you have a pupil expansion ring in, because that'll basically dislodge your ring. Could cause some additional iatrogenic iris damage. Now, here comes the phaco probe. You got your fancy purple phaco needle. Let's see the technique of nucleofractus. Again, I'm watching the video for the first time with you, so we can enjoy together. Try to feature at least 1 resident video every week. Remember, too, we want complication videos. First, never send me a blurry video. We're not ever going to feature it. I'll delete it right away. Don't waste your time. Make sure your videos are sharp and focused. We can have routine cases like this, which are okay, but we prefer complications. So, okay, groove down the middle. That looks pretty reasonable. Try to keep the eye in primary. See those 4 Purkinje images? Keep them in the middle as you do the groove. Don't let them move around so much. You want to keep the globe basically fixed. So that's a reasonable depth groove, maybe at least 50% depth. Let's see, the chopper goes inside or the hook, and you can split this. All right, beautifully done. Hopefully you're going to do a stop and chop, and then rotating that. I don't know if you fully propagated that. And now, okay, stop and chop. You got good hands. You're doing a beautiful technique here. I do like it. Very good job. By the way, the initial groove you made and the split were okay. Notice how the drapes are annoying right now. See how you're not keeping that in primary. Where's the Purkinje image? Not in the center of the cornea. See, it's near the incision. The Purkinje image is near the incision because you're not keeping the eye in primary. Put your right hand down. Push your right hand towards the floor of the room and get that's better. A little bit better. Still not good. Now you see the draping is not so hot. Now the lashes are poking on the cornea, and a part of your cornea, part of your surgical field is blocked by that drape because you're not keeping that in primary. Again, put the right hand down. Keep the Purkinje in the center. That's better. It's not perfect, but it's still better. And now get these pieces out. And again, next time, do a better job. Plus, I think get the patient's chin up a bit. If the patient's chin is down, you're going to have this weird position like you do now. Again, see how the drape is blocking a couple millimeters of the cornea? Why? You don't need that grief. At case 260, you know better. You watch Cataract Coach video, so I got to give you a little bit of ribbing for that. By the way, did I tell you about running around our sister channel? If you're a resident, it is a no-brainer. You must subscribe. You must know this information. It will be on your board exam, I promise. Now, eye probe going inside the eye to clean this up. Again, get the eye in primary. Don't keep pushing the eye. See, you keep pushing the eye inferiorly. Don't do that. I need the eye to stay in primary. Maybe your professors, your consultants, your attendings are too sweet to you. I don't know who you are, so I'm going to tell you straight up. You got to keep that in primary. That's a giveaway that you're a newbie surgeon. You could be doing better. You have better hands than this. I just wish you did better draping and kept the eye in primary better. That's my criticism so far. I like your stop and chop technique. Honestly, that's really good. You could probably even move up to just straight chop. But here comes the last bit of subincisional cortex. Now the eye's in primary. See, look at the light Purkinje image now. When you get the subincisional stuff, now finally the eye's in primary. Again, you want those Purkinje images in the very center of the cornea for the entirety of the case, or most of the case. Now that's cleaned up. A little bit of subincisional cortex there, I think. Now viscoelastic going inside. And let's get that lens in the bag. And again, why put a pupil expansion ring in it? Oh, whoa, we're really enlarging that incision. Next time, can you hold the eye while you enlarge it? Why do you need such a mega incision? I don't know. Maybe the patient's got some steep axis on that meridian or something? Because that lens would have gone through a smaller incision, but okay. Get that lens rotated around, get the haptics opened up. Let's look at the rexus size, pretty good. Good overlap there, 6 millimeter optic. So this looks like the 6.25 ring. I don't think you need it in the first place. So gently disengaging it. And then let's see how you remove it from the eye. Get all 4 scrolls off the iris edge. And again, this is not a totally benign thing. It does damage the iris. There's no question about it. And so here, just grabbing it there. There you go. Explant and gone. Throw that thing away. So I don't think you need the pupil expansion ring. I don't think it really helped you in this case. And I really wish you do a better job draping and keep the eye in primary the entire case. Now, look, you made that incision too big for no reason. Now you got iris prolapse. Please tell me that the patient had a steep axis there, with the rule still, and you wanted to fix it, and you didn't want to do an opposite incision for some reason, because that's way too big of an incision. Oh, gosh, more iris prolapse. Come on already. I was giving you nice praise here. You got to do better than this. And I hope you put a suture in now. If you had that much iris prolapse and you made that big of an incision that you didn't need to, now look at all the inflammatory material inside the eye, you better put a suture in. Don't just hydrate. Where's the 10-0? All right, listen, you got work to do. Again, you're anonymous, so we're being totally frank here with you, and I don't know who you are, but please, you're doing okay, but you got to do better. Come on, step up your game. And remember, subscribe to Retina Rounds. All residents must learn from retinarounds.com.